I actually have 3 appointments, mainly Cold Spring Harbor Laboratory and Weill Cornell. I used to be at University of Cambridge in the UK, and I still have an appointment there. And it is there that the phase 1 trial is being conducted on inhibiting CXCR4 in patients with microsatellite stable colorectal cancer and pancreatic cancer. The importance of the trial is that these are 2 types of the cancers that do not respond to contemporary immunotherapy, including T-cell checkpoint inhibition. So there is a need and a question of whether or not these tumors can be susceptible to immunotherapy, and what does it mean that they do not respond to anti-PD-1, anti-PD-L1, and so forth. It has been considered in the clinical literature that these tumors are not responding to T-cell checkpoint inhibitors because they have not induced an immune response, and therefore promoting a T-cell reaction when in an individual who doesn't have T-cells specific for cancer cells is not going to be effective. So the first hurdle that we had to overcome was to find a mouse model of this type of human cancer. And we collaborated with a person named David Tuvison, who developed a mouse model of spontaneous pancreatic cancer due to, he genetically manipulated the mouse. And the mouse develops pancreatic cancer in about 3 months. And it exhibits the features of human pancreatic cancer immunologically and in terms of response to chemotherapy. We discovered that T cells are excluded from infiltrating amongst the cancer cells because the cancer cells are actually coated with a chemokine CXL12. They're not making it. The fibroblast cells in the tumor make the CXL12. And the CXL12 engages its receptor, which is CXCR4, on the T cells, and that interaction excludes the T cells from entering the cancer cell nest. And that's why the tumor escapes immune control, even if the mouse has T cells specific for the cancer cells. By blocking CXCR4, the receptor for CXL12, with a small molecule inhibitor that's actually approved for clinical use to release hematopoietic stem cells from the bone marrow, it's called AMD 3100 or Mozobil or Prolexafor. If giving this to mice allowed T cells to come in amongst the cancer cells and kill the cancer cells, halt the growth of the tumor, and now the cancer became sensitive to a T cell checkpoint inhibitor, anti-PD-L1. So this is all in a mouse. So what happens in humans? Unfortunately, we were teamed up with a pancreatic cancer dream team led by Liz Jaffe at Hopkins and Bob Vonderhaat at Penn. And at that time I was in Cambridge. We were teamed up with them to allow us to do a phase 1 trial of continuous administration of AMD 3100 to colorectal cancer patients and pancreatic cancer patients with microsatellite stability, so a low mutational burden. And we found that comparing biopsies taken from liver metastases before treatment versus at the end of treatment, and an RNA-seq analysis of the transcriptomes of the biopsies, we found that 1-week administration of AMD 3100 upregulated immune pathways involving T cells, B cells, and in fact, the top immune pathway upregulated was allograft rejection, which is transplant rejection, which is precisely what you want to have as your anti-tumor immune response. We compared the genes upregulated by AMD 3100 in the tumor with genes upregulated by successful treatment of melanoma patients with anti-PD-1 in a published study by other authors at Sloan Kettering. And we found the same pathways were upregulated with AMD in this tumor that does not respond to checkpoint inhibitors, colorectal cancer, as was upregulated with anti-PD-1 clinically successful treatment of melanoma. So we didn't have a clinical outcome because it's a 1-week treatment of monotherapy, but we think these data justify now proceeding on with a phase 2 trial of combination therapy of inhibiting CXCR4 plus an anti-PD-1 checkpoint inhibitor. We are discussing the trials now with our potential collaborators, and that's about as far as we are. First, of course, we did our mouse model in pancreatic cancer. The most data we've had, we have 11 colorectal cancer patients in our phase 1 trial, and so we're seeing a response in colorectal cancer. Both colorectal cancer and pancreatic cancer, the human cancer cells are coated with CXL12. Non-small cell lung cancer cells are coated with CXL12. We've done that with our collaborators at Weill Cornell. The literature reports that ovarian cancer cells are coated with CXL12. So I think there is a good possibility that this might be a general means by which epithelial cancers protect themselves from immune attack. It's not going to be limited to pancreatic and colorectal cancer, but we don't know. I would be worried about resistance if there were not at least several antigens evoking the T-cell response. If there's only one antigen, then you could imagine a tumor might downregulate the expression of that antigen. The other problem, though, with all immunotherapy, it's inherent in immunotherapy. The pathways we're talking about evolved to protect normal cells. And so anti-CTLA-4 is associated with a pretty high incidence of autoimmunity. Anti-PD-1 therapy can be associated with diabetes, endocrine abnormality, autoimmune endocrinopathies, colitis. So we don't know yet what normal tissue reaction we might provoke when we inhibit CXCR4 in humans. But, you know, that's kind of it'll be interesting we don't yet know why this pathway evolved. What tissue is being protected normally by this pathway? And I'm very interested in that. I started out life as a physician treating autoimmunity. I'm now potentially discovering a pathway that blocks autoimmunity.